A lot of surgeons or GPs who are doing surgery like to plan their case on a CBCT planning software first, and that's fantastic. What a surgical guide can do is actually bring that plan into life. We can bring that plan physically into the patient's mouth, which is fantastic. And we can do guides all the way from pilots to prosthetics. So speaking of that, what are some more dialed in guide parameters here? What are our options for guides? We can certainly talk about the positioning. That's a big thing. Angulation and depth. So we can control the three main, vectors for implants. And then we can also control things like width, placement, and prosthetic. First thing we're going to do is diagnose the case. Of course, we're going to do treatment planning based on the whole host of factors. And then we're going to take a CBCT. Okay, choose your field of view that's relevant to the treatment considerations. If it's the first time I've met a patient, I'm taking a large field of view, because the last thing I want to do is have a patient come into my office and say, hey, I need an implant upper left. And I just take that quadrant scan and I miss some pathology on the lower right or some, other disease elsewhere. But we're going to bring that digital file into your CBCT planning software and overlay them or mesh them on top of the patient's 3D X-ray. And this is what allows us to have an intimate fit of our surgical guide that is lined up with the patient's actual bony anatomy. We're also going to be mapping some anatomy. So it's probably like the IA and the mandible is going to be mapped. We're going to make sure that we're staying far enough away from that. But it's important to have some sort of wax up. Now, most of us, 389 of us here that are watching this right now, can do this kind of wax up in their minds. That's not that hard. And I'm totally fine with that. Like, you can certainly imagine, okay, somewhere between 18 and 20 is number 19. It's not rocket science. But if you're doing something like a bridge, or certainly if you're doing a full mouth, you really ought to have a pretty clear idea of where the teeth are supposed to be in space to give yourself the best options. Okay. So now we have the STL overlay, and the importance of this is it has to be well stitched, and stitching is how tightly meshed it is to the patient's hard tissue CBCT. And it has to give you a perfect overlay, because if you're off by a little bit in the stitch, that could mean that your drills are going somewhere you did not plan for them to go, especially if we're working in tight spaces, right? So now we're looking back at the CT, and we planned, based on the the ideal position for the future restoration. Okay, great. That's where the implant's going to go. Now let's go down to the actual hard tissue CBCT and make sure that that is something that can be accommodated for the implant that we want. We're aiming for our implant to be parallel to the adjacent contact points. Okay, there's an old school that I still hear parroted back to me when we're teaching courses, that don't you want the implant to be parallel to the adjacent roots? I do not care about the adjacent roots as long as I'm not touching them or within 1.5 millimeters of them. We're going to create the guide. Lots of different ways to do this, lots of different softwares to do this. Essentially, what we're creating at this point is a suck down with a hole in it that fits a metal sleeve. Okay, and that sleeve is what matches up to your implant company's branded of guided surgery sleeves. So here's our final result. We export this and then we print it.